Okay, this is actually my third recording of this because turns out I forgot to record this with a microphone turned on. So hopefully it actually works this time. This episode is about 15 to 17 minutes based on my last two recordings of black video with no audio. This episode is Everything Large Bowel, and I wanted to start introducing some new things to the episodes. Really, I just wanted to add in a short segment right at the beginning of an episode where I just do a very brief study tip or tidbit that I learned during PA school that isn't clinical but is super helpful when it comes to preparing for the board exam. This week's episode is just going to be, or this week's tip is just going to be to make a plan. If you go through clinical year and you decide to wing it, I can't stop you. Actually, I had a lot of friends who did that and they did just fine on their board exam. Really, they didn't need to. I am not that type of person. I need a plan. I need to know what I'm studying when, and I need to be able to be held accountable and hold myself accountable and make sure that I'm not going to miss some type of content because I'm just using the force and trying my best. When you go to make a plan for the year, during your clinical year in particular, you're preparing for the pants. I did an 8-week study plan for before the pants, and then every month before that, I essentially made a new study plan based on whatever rotation I was in, and I would break it down month by month. So I didn't plan out my whole year at once, but in January, I did my first rotation, and it was 5 weeks. So I took a calendar. I said, this is my first day, this is my last day. And on each day, I said, I want to study XYZ specialties or topics, and I'm going to study them by either reviewing notes or listening to a podcast or taking a test. I tried to do one test a week that was 60 questions and timed. And then outside of that, I really just let myself do whatever I wanted to. But I did have a lot of specificity put in there. I would say that I really wanted to do these three topics. I gave myself 30 minutes. I let myself do 20 questions every single day. And then that was it. That being said, I did have to adjust everything based on whatever rotation I was on. For example, I did a rotation where I worked a 5-day week, which means I studied for maybe 45 minutes to an hour every day. But I also had rotations where I did 13-hour shifts or 12-hour shifts or night shifts. So I adjusted my studying based on whatever my schedule was going to be. Take that mentality in with you when you start your clinical rotations and hold on to that idea as you go to make your study plan. Be flexible, but don't wing it. Unless you want to wing it, in which case you really can. I would recommend not winging it. This week, I'm going to be starting us off with appendicitis. This is the most common surgical emergency of the abdomen. It happens, we associate it mostly with pediatric patients. And to be sure, appendicitis is the most common reason for emergency surgery for children because the risk of perforation is so high in those kids. But appendicitis does happen in adults and in all ages. It's very common, actually. The etiology is going to be things like fecaliths, inflammation, foreign bodies, or even neoplasms. What happens is you have some type of obstruction that causes increased pressure and venous congestion that eventually thromboses and then causes infection, eventually gangrene, perforation. You get the gist. If you have an appendix that perforates, you're going to be leaking stool into your abdomen, so bear that in mind. Something I love about general surgery is that it's a lot of common sense logic. If you're leaking stool out of the colon, that's not good. History-wise, you're going to have a colicky periumbilical pain, which migrates to the right lower quadrant and becomes steady. These patients will also have nausea, vomiting, a sense of constipation, possibly a fever, and a low appetite. On physical exam, we all know the right lower quadrant tenderness is really focal for this one, but there are 4 signs for appendicitis, and I have a couple unique ways for remembering these. The signs are psoas, obturator, McBurney, Rovsing. I like to remember psoas and obturator together because they're muscles, and so I just remember what the muscle does, and that tells me what I should do to test for it. For example, psoas sign, pain with passive right hip extension or active flexion. So the patient can either be laying on their belly and you lift their leg up towards the ceiling, which is not going to happen most often, or they can be laying on their back and you can actively flex their hip and have them push against you. Obturator sign is pain with flexion and internal rotation of the right hip. McBurney's point is the next one. I think of McBurney's point as Murphy's annoying downstairs neighbor. So Murphy's is upstairs, and then McBurney's is in the basement. McBurney basement. So right lower quadrant. That's how I remember to keep them separate. McBurney's point is 2/3 the distance from the navel to the ASIS. You push down there, and it's going to elicit some pain. Rovsing's sign is pain in the right lower quadrant when the left lower quadrant is palpated. R for right lower quadrant pain. O, opposite. Zing, sign. Rovsing sign. So it says it in the name. So recap real quick. Psoas sign, pain with passive right hip extension. Psoas, pain, or active flexion. Obturator sign, pain with flexion and internal rotation of the right hip. Obturator, rator, rotation. I remember it that way too. McBurney's point is Murphy's downstairs basement neighbor, 2/3 the distance from the navel to the ASIS. And Rovsing is R for right lower quadrant pain, O for opposite, and it's a sign. You can have some atypical presentations, particularly in populations such as elderly patients, pregnant patients, or kids. Diagnostic workup is going to be labs and an abdominal ultrasound. The lab work is going to show a leukocytosis. And on imaging, you're going to primarily, like I said, get that abdominal ultrasound because it's the most convenient, it's the least invasive, and it's pretty quick. CT scan is the most accurate imaging, and it's the ideal one. If you are me, I want you guys to get a CT scan with IV and PO contrast. The treatment is going to depend on the type of appendicitis you have. Generally, if you have an uncomplicated appendicitis, meaning just inflammation of the appendix, you can do a laparoscopic appendectomy with pre-op antibiotic coverage, discharge from PACU, post-op them in 2 weeks. Then, once you get past that, it gets a little bit more complicated. After this, it becomes a little bit more dependent on the situation. For example, one of the complications of appendicitis is actually perforation. If you have a patient who on CT scan shows perforation and they're stable, you can consider doing non-op management with antibiotics, IV fluids, NPO status, and possibly doing an IR drain. If they're unstable and you see this perforation on CT scan, they go straight for emergent laparoscopic appendectomy, possible/probable open. Those patients can often end up with a ileocystectomy or a removal of more than just the appendix, basically, and so it becomes a little bit more of an intense surgery. Then, in addition to that, we also can end up with perforation that we don't pick up on CT scan, but you just happen to find in surgery. Those patients, we manage it in surgery as we need to. We remove the appendix, and then those patients often get a surgical drain placed, particularly if there's contamination from stool leaking or an abscess or bleeding. And then we also admit those patients and they get post-op antibiotic coverage for a period of time. The new data is showing that antibiotic coverage for sepsis you need to be giving for 4 days after source control is obtained. So you can't just know about it and be giving them empiric antibiotics. They need antibiotics for 4 days since source control. So that's really that one. Diverticulitis is next. This is inflammation of diverticula, which ranges from mild to severe. Diverticula are the outpouchings of the sigmoid colon most commonly, although it can be on the entirety of the large colon. The etiology is not quite clear, but bacteria certainly doesn't help matters. Physical exam or clinical presentation is going to be left lower quadrant pain and tenderness with possibly a fever, nausea, vomiting, constipation, bloating, or diarrhea. If there is evidence of perforation, they are going to have peritoneal signs or global abdominal pain. Your differential is quite broad. You're going to have things like colon cancer, IBD, colitis, ovarian cyst torsion. All these things are on your differential. Diagnosis, you're going to get some blood work, CBC with autodiff, BMP, fecal occult blood test. You're going to see some leukocytosis and possibly some electrolyte changes, especially if you have a patient who's having a lot of diarrhea or vomiting. Imaging is going to be a CT scan, which is your initial imaging of choice. We do not typically do colonoscopies while they have an acute diverticulitis going on because there's an increased risk of perforation. That being said, treatment. If It is an uncomplicated mild case. We treat them outpatient with oral antibiotics like Flagyl and levofloxacin or ciprofloxacin for 7 to 10 days and give them a clear liquid diet. And then in 6 to 8 weeks, we get a colonoscopy and see what's up. In moderate disease or criteria for admission, basically, that's when people are febrile, they're not tolerating any PO intake, they have a profound leukocytosis, they may have focal peritonitis. Those patients end up with IV antibiotics for 5 to 7 days, NG2. We usually advance their diet as tolerated based on return of bowel function and resolution of symptoms. If they get 3 to 4 days into that conservative management and nothing is better, then we usually recommend repeating imaging and seeing where we're at, and then possibly offering them surgery that admission. Again, we're not going to offer a colonoscopy because it's not going to be a great idea to do during this acute setting. That being said, we do like to get them through the acute setting without surgery, ideally 6 to 8 weeks for things to settle down, colonoscopy, and then eventually we usually offer elective surgery. If we have to do surgery that admission, we often have to do a hemicolectomy with colostomy creation and eventually offer them reanastomosis at a separate surgery, whereas oftentimes for elective operations, we can do a primary anastomosis in the same operation, meaning remove the disease section of colon and reconnect everything. There are complications associated with diverticulitis like perforation, abscess, fistulization to other organs, and stricture. It's pretty common to have recurrent diverticulitis attacks, and so this is one of the conditions that we do consider doing elective resection for. Next up is large bowel obstruction. The most common cause is neoplasm, and if we see this neoplasm, we have imaging for it, and they have obstructive symptoms such as nausea, vomiting, bloating, constipation, we will go in and remove it. There are lots of other reasons that can cause a large bowel obstruction, such as hernias, diverticulitis, inflammatory bowel disease, and there's even a condition called acute colonic pseudoobstruction. Now, for that, we don't operate on that generally, although there are times when you do, but what we do for them is bowel rest and serial abdominal exams, monitoring lab work, and hopefully let their bowel calm down on its own. That's also a situation where we try not to do a bunch of scoping because of the risk of perforation. And for them, we do advancing diet as tolerated with bowel function and resolution of symptoms, or surgery if we need to. That is really it for large bowel obstruction, just because I didn't really go into too much detail with it. I don't know that you're going to get a ton of questions about it. And I know that this episode is super short. I think I'm going to keep it around 15 minutes, maybe even less. And that is just simply because the next part is going to be pretty long. It's going to be inflammatory bowel disease and anal conditions. And I wanted to kind of keep things short and sweet with these episodes. I hope that you guys feel comfortable giving me feedback. I'm doing my best to keep them as succinct as possible, but also put in information that is helpful for the test, plus like 1 or 2 tidbits that you may use in clinical practice or on your rotation itself. So that way you get the best of both worlds. There's plenty of resources out there. I hope everybody is utilizing all of them. I think variety is the spice of life. And I would really appreciate any advice you guys have for me on how to make these episodes better. I hope to make small changes every once in a while just to continue to improve myself. I'm also sharing my notes that I've used for my rotations and that I'm using for this show. And it's going to be on one master document that you can actually access on my show notes down here. So let me know what you think about those. And that being said, I will see you guys next time.